Okay, maybe we can get started while folks trickle in. So, hi everyone, I'm Archie Pallam and I have Jenna Kahn with me. So, welcome. This is our fifth Rover session, a summer series to connect med students to faculty across the country to go over radon cases while rotations are on hold. So, excited to have everyone join us, excited to have our faculty panel today. So today's cases will be in breast and sarcoma. We have two breast cases, one sarcoma cases, and the format will be, so we'll start off with introductions, and then we have our resident moderators go through the cases. We'll have poll questions for the students to answer. And students, if you have any questions, just feel free to use the chat box. Make sure that your questions are addressed to the panelists and attendees so everyone can see the questions and answers and benefit from them. Okay. Any other logistics, Jenna?
I think that's it.
Okay, so maybe we could start with the moderators. JP and Chris, do you want to just introduce yourself and maybe tell everyone a little bit about yourselves and why you went into radiation oncology? And then you guys can introduce the faculty panelists and they can share a little bit about themselves as well to all the students.
Sure. So I guess I can start. Hey everyone, good afternoon. I'm JP, one of the PGY4s here at Stanford. And I'm on my research year, which is why I'm in, I guess, normal attire, which is pretty nice right now. I went into RadOnc for a variety of reasons. I sort of came from like a physics background, and I really loved the interactions that I saw when I was rotating as a med student between the attendings and patients when sort of helping them through their cancer journeys. And sort of put all that together, I found that it's the right specialty for me. And since till now, I haven't disproven that. So it's great and I love it.
Thanks, JP. I'm Chris Dyke. I'm also a PGY4 at Oregon Health Science University. Complex question, but in short, I liked how team-based radiation oncology was. I mean, you work with so many different professionals, radiation physicists, dosimetrists, therapists, other radiation oncologists, surgeons, med-oncs, and anywhere in between, translational scientists, etc. And I found that pretty fascinating and unique for sure. And I also had a particular interest in, still do in palliative care, which is a big part of our practice. And you can have some unique interactions, some really fulfilling outcomes, which is a part of our daily practice.
Great. Maybe we can move on to the faculty now. We can just start in order on the slide. So Dr. Gillespie.
Yeah, I'm Erin Gillespie. I'm at Memorial Sloan Kettering Cancer Center. I mostly treat breast cancer, as I will try to not comment on the sarcoma cases today, since that is no longer my expertise. And, you know, RadOnc, I was lucky to have a mentor in college, actually, that happened to be a radiation oncologist who balanced, you know, running a lab and having a family and being an excellent clinician. And so to me, it was like early exposure. And then, you know, realizing in medical school, the multidisciplinary nature of the field, you know, where it's really a decision by consensus, often with colleagues, and really just being able to have time to counsel patients. So, you know, there's a lot more things, but I think those would be the main ones.
Okay, great. I'm Kate Horst. I'm at Stanford, and I primarily do breast also. And I went into radiation oncology because I really liked oncology, but much like the other comments, I really like the interdisciplinary nature of radiation oncology and the imaging combined with the technology. And we interact a lot with all different specialists, pathologists, radiologists, med-onc, surg-onc. And so I find it very exciting, much like Erin just mentioned. It's very team-based decision-making, and also the continuity of care. I mean, we see patients throughout the entire spectrum as well as follow-up. So I think we have really great relationships with our patients, which I really like.
Hi, I'm Chirag Shah. I'm the Director of Breast Radiation at the Cleveland Clinic, and I thought this was tailor-made since I treat breast and sarcoma. So those are my two areas that I cover. And actually how I got into radiation was I was interested in pediatric brain tumors. So I went into radiation oncology with the plan to be a pediatric radiation oncologist, and I now treat breast and sarcoma. And so that's mostly due to mentorship. I was very lucky to train with Dr. Vicini, who's been my mentor and remains to be my mentor. And I kind of shifted my focus from CNS to breast cancer and as well as sarcoma. So it's a pleasure to be on today.
I don't know if Matt's going to go, but I guess I'll go. I'm Corey Spears at the University of Michigan in Ann Arbor. Also treat primarily breast cancer, actually almost exclusively. And as a physician scientist, also have a lab that is focused on making radiation treatments more effective for women with breast cancer. And I think everyone's kind of touched a little bit on what makes radiation oncology interesting for all of us. As Dr. Gillespie mentioned, really enjoy the opportunity to interact with patients for an extended period of time, that we have as an outpatient specialty, the opportunity to kind of work closely with those families, have time to discuss their diagnosis and their treatment path. And that really drew me in a way that perhaps some of the other oncology specialties didn't. And then the opportunity to kind of marry research and clinical care in radiation oncology was really intriguing to me. I knew I liked cancer, but as a medical student, wasn't quite sure if I wanted to do surgical oncology or medical oncology, and found radiation oncology to kind of really perfectly balance clinical care, but also as an outpatient specialty and ability to kind of do lab-based research that I still really enjoy. So excited to be part of this, and I will not comment a ton on the sarcoma case. So.
I'm Matt Spraker. I'm at WashU. I treat sarcoma and lung. I hope all you guys do comment on the sarcoma case, because that's what's interesting about sarcoma is there's so many ways to approach it. I guess I got into radiation oncology a lot, like a lot of people. It was sort of late in the game, and I explored a whole bunch of fields, and then finally stumbled upon radiation oncology, and I was super happy because I wasn't sure I was going to find one that I liked. But I basically went into it because it's a technical field that does team-based care, but we actually got to see patients, and I found a lot of the other technical fields didn't spend as much time with patients as I'd like. So that was my favorite thing about it, and to this day, my favorite parts of the day are like sitting with patients for a long time, and our ability to do that is great. And now a lot of the other oncologists are kind of jealous of that, I think. So that's something that I really, really like about the field.
Great, thank you. And before I forget, I always forget, but I just wanted to thank Navjot Sandhu, who's my admin and who has been instrumental in terms of setting this up for everyone. She is applying to medical school this year, so hopefully we can get her to join RadOnc eventually. So I think we could get started, JP, if you want to present the first case.
Yeah, sure. Let's go for it. So, pardon me, case one. So 62-year-old gentleman presents with an enlarging lump under his right lower neck. So we'll just go ahead and ask the panel, what would you like to know on H&P? And what is the differential diagnosis that may cross your mind in general for an enlarging mass in the lower neck?
Maybe we can start with Dr. Scott to comment, since Dr. Spraker had to go to an SBRT, I think.
Sure. So, when we think about an enlarging lump in the right neck, in terms of differential, I try to break it down into malignant and non-malignant causes. So in terms of, non-malignant causes, anything from infection, and I recently saw even a tuberculosis case that could present this way, to the malignant side. You could think of a head and neck cancer with low neck adenopathy. You could think of a lymphoma, and you could think of anything coming up from the mediastinum. You could also think of a advanced thyroid cancer as well. These are all things that could present there. Sarcoma is obviously a possibility in any location. In terms of the history and physical exam, just a very good history for us to when the patient noticed it, what the rate of change has been, any past medical history that may suggest a diagnosis, any past medical history of cancer, any previous radiation therapy or systemic therapy treatments, any immunomodulation for any type of rheumatologic disease that may predispose them to a malignancy as well. Family history for any family history clusters, social history for smoking and drinking, previous radiotherapy exposure, and then obviously looking for any neck incisions or anything that was previously worked on in the neck. In terms of the physical exam, starting with a thorough head and neck exam. So obviously doing a superficial examination for any cutaneous lesions, palpating the lymph node level, starting at level 2 and working your way down to 2, 3, 4, and 5. And then if there's any suspicion of a head and neck primary, doing a scope to make sure that we don't identify a scope primary. Once those things have all been done, if there's not a clear diagnosis beyond a neck mass, we usually start with some imaging to understand where the mass is coming from, whether it's a node or it's coming from the clavicle or another structure in the low neck. And once we have that imaging, then we think about how we'll procure tissue.
Thank you. Yeah, that was legit amazing and way beyond anything that I put on the next slide. But so in terms of the history, the mass has been growing over the past 2 months. Now they report about like a 3 out of 10 in pain, sort of just from mass effect compression. They deny any dysphagia or dynophagia, other neck lumps, which is important to note if there's sort of other lymphadenopathy or things. They deny fevers, night sweats, weight loss, or any dyspnea or cough or mediastinal irritation. So for social history, as was mentioned, it's important to elicit some of these things. So occupational exposure to radiation through work as a military asset, including being inside nuclear reactors, was a pretty interesting one that we got from this patient. They did not have any prior chemotherapy, and they do deny any smoking, alcohol, or other illicit substances. So on exam, we were able to elicit a firm, non-mobile 5.5 cm medial lateral by 5 centimeter sup-inf mass, which was arising from the inferior right sternocleidomastoid, sort of in this area, and extending from the right clavicle to the level of the cricoid cartilage up in the neck. As was mentioned, you do a pretty thorough lymph node exam, and no other cervical, supra, or infraclav lymph nodes were appreciated on exam. So we'll go ahead and get to our first poll question, which is, what would you suggest doing next? The options are to proceed with a CT of the head and neck, punch biopsy, an MRI of the neck, or start them on an oral antibiotic course. Great. So about 80% of respondents voted. Majority believe CT head and neck, and some think an MRI would be an appropriate next step, although some think that perhaps we should try antibiotic course or a punch biopsy. Dr. Shaw, would you have any sort of opinion as to what would you do to?
Yeah, so I think that, antibiotics, if this wasn't such a firm fixed mass, it was a fluctuant lymph node style thing, that might be a reasonable thing to consider. I typically wouldn't do a punch on something that we think is deep seated like this. Honestly, I would love an MRI, but unfortunately, I think this is a pragmatic answer, is that most insurance companies wouldn't approve an MRI off the bat. So I'd probably start with a CT head and neck with contrast to understand kind of where the mass is originating from, what its relationship is to the neurovascular structures, and also potentially if it's getting anywhere near close to the clavicle or the chest wall below.
Great. So we actually do have an MRI on this patient, which is nice. The report reads an enhancing lobular mass in the low anterior right neck arising within the sternocleidomastoid muscle, measuring 4.1 by 3.2 by 5.5 cms with no associated lymphadenopathy. And they do have internal components consistent with hemorrhage or necrosis. So the way we kind of organize this is this superior most, and then it goes like this, sort of counterclockwise towards the inferior most. So I would ask the panel to perhaps tell us what you see on these representative slices and what this may suggest.
I think Matt's back. Matt, do you want to take this and then we can kind of alternate back and forth?
Sure.
Sorry, so the question is what do I see here and what does it suggest? Is that what you're asking? Yeah, okay. So yeah, I think this is an MRI, this is axial slices of an MRI. It's probably a T1 weighted image, and you can see that the vessel, I don't know if you guys can see my arrow, but the vessels are sort of lighting up or bright on this image, so it indicates that there's some contrast that's used here. And I think that the description on the screen is exactly what you'd be looking for. So the size is important, and then as was mentioned by Dr. Shah earlier, the relationship to the neurovascular structures, which really speaks to resectability of what this is. We're getting a little bit ahead of ourselves, but I think that that's exactly sort of how I would approach it. The lymphadenopathy is also an important thing that we maybe will touch on a little bit later, about what that might give you a clue about what this might or may not be. And then they do usually comment on these kinds of images about internal heterogeneity. And what I mean by that is that the appearance of the mass on the image will have basically different gray scale throughout it. And that can often reflect bleeding or hemorrhage, which can happen. It also can reflect what radiologists will call quote necrosis, which can represent dead parts of the tumor. Or I don't know if we have a great evidence of what that's related to specifically, but we often see sarcomas that will have these kinds of different appearance on the inside of it, and it speaks a little bit towards maybe the aggressive nature of it.
Great, thank you very much, Dr. Spraker. So because of these imaging findings, we did opt to get a CT guided biopsy, which is different than the punch biopsy that was on the previous poll. So it's important to note that this is more sort of for deeper tissues that we're trying to take. And the pathology returned high-grade sarcoma with a fibroid myxoid stroma. And the comments were that it was negative for SOX10, Melon-A, and S100, negative for Desmond, CD34, and CD117, with a differential favor to include a myxofibrosarc or an undifferentiated pleomorphic sarcoma. And so the question to the panel would be, how would you use this information, specifically the grade, to classify the different, what you would kind of like imagine the sarcoma to behave like?
So, from my standpoint, obviously grade for the students and everyone, it helps with staging in terms of higher grades with the same size as lower grades are going to have a higher stage. But to be honest, I think at least, in my experience, in our group's experience, we're even moving past grade to really look at the subset histology. And so what's really important to me is the myxofibrosarcoma versus the UPS or undifferentiated pleomorphic sarcoma. And the reason is that when I look at the imaging and I see a myxofibrosarcoma, I'm going to have to really think about my margins and potentially being more generous. When you talk to our surgical colleagues, these myxofibrosarcomas, often you go to surgery and they think they have widely negative margins and they keep taking and taking and taking. And so grade is important, but I would actually say histology is just as important, if not more important. Not sure what Dr. Spraker thinks about that.
Yeah, I'm so happy you said that, because it's like I totally agree. I think there's not actually great data about this, but I think it's sort of this like unspoken rule that all people that do sarcoma kind of have about myxofibrosarcomas. They have a high propensity for local recurrence and they're very infiltrative. So surgeons and radiation oncologists tend to be pretty generous with treatment local treatment on these types. So I do agree with it. It's one of the couple of other types that we maybe treat a little bit uniquely beyond grade are malignant peripheral nerve sheath tumor and angiosarcoma. And some of those actually at some centers are ungraded because they're just like high grade, like no matter what they look like under the microscope. So, but just to be explicit, since we're supposed to be teaching some of the basics, I think the grade is actually a standardized system. So it's the French national group kind of came up with a standardized system that's a little bit like, I'm a little distant from this in my residency, but how they grade breast, where there's components that add up to a score, and it's a score of 1 to 3. And when they say high-grade sarcoma, they really mean an FNC-LCC grade of 3, which speaks a lot to the aggressiveness of it. Multiple studies have shown that that grade is independently associated with local failure as well as metastatic disease and then overall survival. So this just speaks to the aggressiveness of this cancer.
Great. Yeah. Thank you very much for the input. So it's good to know that, histology is just as, if not more important than grade for some of these SARCs. At this point, we would have another poll question for the audience. Which treatment algorithm would you suggest? Do you think we would perhaps try and proceed with surgical resection or pre-op radiation followed by surgical resection, as this would allow for a lower radiation dose? Should we consider surgical resection followed by post-op radiation, as this would allow for a lower radiation dose? Or should we try and offer concurrent chemoradiation? Okay, great. So we have about 80% response. And I think it's pretty good that we have sort of a mixture between these answers, specifically the two middle answers about which one may be better pre versus post-op and which one would actually allow for a lower radiation dose. So I would defer to the panels, Dr. Shaw and Dr. Spraker, as to what you think about pre-op versus post-op radiation. And we'll go into more detail about this in a minute.
Sure. So, for the students, I think it's important to understand the historical context. So, when we started treating sarcomas, we were primarily doing amputations. And as we worked our way through, the original trial, including the NCI trial, compared amputation to surgery plus postoperative radiation. So postoperative radiation was the de facto standard of course for many years. We then began to challenge that idea with the conceptualization of preoperative radiation, allowing lower dose to a more well-defined target that's more oxygenated. And so we did the NCIC trial, which looked at pre-op 50 gray versus post-op 60 gray plus or minus a boost for the pre-op arm, depending on factors, and found really, despite the initial early findings, that they're relatively comparable with respect to clinical outcomes, but that pre-op offered reduced late side effects with the potential for acute wound complications. So what that means for this case and in general is we weigh the pros and cons. And in this case, in the location, I would definitely favor pre-op over post-op. One, it's a more well-defined target. Two, though I may not get a lot of downstaging with myxofibrosarcoma, I may get some to facilitate a smaller surgery. And then number three, the location may make giving post-op, if there's closer positive margins, more difficult due to the brachial plexus sitting right there. On the flip side, an anterior groin mass where you worry about wound complications, you may have a discussion with your surgeon and consider post-op over pre-op.
Yeah, great. Thank you. So this was basically the same kind of slide to review the pros and cons of pre-op versus post-op. And so in terms of the management, he was first systemically staged with a PET CT to make sure that he was negative for distant Mets, which was the case. And then preoperative or neoadjuvant radiation with plans for surgical resection afterwards was basically recommended. And there was no role for systemic therapy at this time. So Dr. Spraker, would you please give your thoughts about how you would set this patient up, and then perhaps like what target volumes and radiation dose regimen you would prescribe for this pre-op course?
Yeah, so the way that I would approach this case is I would basically bring the patient in for a CT simulation, and I would have them set up supine, probably with their arms down, but this is probably a good time to just remind, I always remind trainees here that it's really, you want to really work together with your radiation therapist to identify an optimal setup. And this is somewhat of a tricky area because it's like sort of in the low neck, not quite in the upper extremity, that kind of thing. So I think in this case, realistically, probably it would be, supine with arms down and then having their head turned slightly away from the mass to give yourself some space to treat. And I always, in patients that can tolerate it, I tend to sim patients with IV contrast because every time I don't do it, I regret it. So I tend to use IV contrast for this patient. And I would also fuse a PET CT, which doesn't really help with delineation, but it's just kind of a secondary check to make sure that you've kind of covered everything that's elevated on the PET CT or that has hypermetabolism there. In terms of target volumes, the way that these designed, I designed them in the same way that I think most people do, which was kind of set by the recent RTO G0630, which was a clinical trial that looked at smaller margins for radiation therapy in the pre-op setting compared to what was used in the SR2 study. and then also much smaller than what was used in the initial study that originally established resection and radiation as the standard of care over amputation. And that's an important thing because a lot of these studies are older and the toxicities are quite high, or quite common. And I think these days with these small fields, the toxicities are much more well tolerated. So what you would actually do is draw out a gross tumor volume based on the MRI. Rarely you can actually look at the T2 of the MRI. I don't know if we showed that here, but there can be enhancement on the T2 scan outside of the gross tumor mass, and that needs to be covered as well. But you basically take those two things into account and make a gross tumor volume, and then you set yourself a CTV volume. And the CTV volume is really meant to be defined to cover likely anatomic spread of microscopic tumor cells from the tumor itself. In this kind of a situation, it can be a little bit challenging because in an extremity, there's a clear radial and distal, sort of proximal distal or kind of craniocaudal coverage that you would do. And just to be explicit, in most cases, like in an extremity, it would be 1.5 centimeters radially around the tumor, and then something like 3 centimeters craniocaudal for a high-grade tumor or a large tumor. In this case, what I would say is I tell my residents that I actually use like a 1.5 centimeter pen radially, and I'm usually a little bit generous with it. And I would say that my volumes for a mix of fibrosarcoma probably trend closer to 2 centimeters radially because we've kind of talked about how they're quite infiltrative and can have local recurrences with tight fields. So that's how I would define it. I think here, if there's not a clear, two things I would add is if there's not a clear craniocaudal versus radial direction of spread within a compartment. And what I mean by that is if the tumor cells can truly spread in any direction, it probably makes sense to cover it 3 centimeters in all directions. The other thing that I would just add is that these volumes are really small, and you might add a 5 millimeter PTV or setup error margin on your CTV that covers gross tumor or microscopic tumors extent. And when you do that, you really, really need to image them daily. There actually was a secondary paper published out of RTO G0630 that showed that if you're just imaging once a week, how some people might do for other types of cancer, you're going to be missing the tumor or your CTV quite a bit because there's a lot of motion in these areas. So it's important to image daily if you're going to use really tight fields, or at least accommodate for that if you're not planning to. I was trying to think, there's only other thing that I wanted to add. Yeah, and the dose to the whole thing, 50 to 25 fractions is typically what we will treat. I don't know if Dr. Shah, if you want to talk about alternative fractionation, which is becoming more and more maybe common or exciting these days, but there's other ways we can do this as well.
Yeah, so a couple things. I think for the students, one of the things that's changed since I was a student and now a resident and attending is MRI simulation. So I'm not sure an MR sim is hugely needed here because it's a relatively stable area, but in an extremity, an MR simulation is amazing. So fusing an MR that was done for diagnostic purposes to a radiation CAT scan can be like playing Jenga at times, in my opinion. And so doing an MR simulation where you do a CAT scan and then you do an MR in the same position, in my opinion, really enhances the ability to delineate anatomy as well as GTV, CTV, PTV. And I completely agree with Dr. Spraker in terms of image guidance and dose. The only thing that we do sometimes here is two things. Number one, if there's an area that we're concerned is going to be a close surgical margin, we may actually heat up that area. And instead of giving 50, we may contour a secondary volume and treat that to a higher dose of, say, 55 to 60 gray to try to help facilitate downstaging. And to Dr. Spraker's other point, we've started looking at short course pre-op. So this has been done for years in other centers, 30 and 10 even was done, 20, 30 years ago. We've started looking at doing 30 gray and 5 fractions preoperatively, and then going to surgery within 72 hours. So our team has recently published that, and that's similar to the UCLA approach, which also includes chemotherapy. We wouldn't probably do it in this site in terms of in the head and neck area. We tend to do it more in the extremity area away from a joint, but that is definitely something that we're looking at.
Great, thank you very much. So actually, you guys covered everything ahead of us. So, some of the variations that we had were about if the tumor had been in the extremity, how would we have approached it differently? And it's good to keep in mind what we fuse to our actual CT simulation as well as what we use for image guidance. So I guess we should move on to case number 2. And this one is a little bit different in flavor, and I can go ahead and present this one as well. So 60-year-old woman with a past medical history of hypertension presents following screening mammogram, followed by diagnostic mammogram with a suspected abnormality in her right breast. So we'll direct this to the breast panel. What factors would you aim to elicit in a focused history for a breast patient? We can leave the physical for the following case. Perhaps Dr. Spears?
Yeah, sure. So I guess this who wants to take this question go first? It's almost like oral boards for us as well. So this is really important, certainly for medical students and for residents. Anytime you're thinking about doing a focused history and physical on any patient presenting to a radiation oncology clinic, you really want to, oftentimes we are seeing them after they have a diagnosis. And so asking about what you're going to assess in a history and physical on a patient without that diagnosis, you're thinking about the things that would then predispose them to having a malignancy or not. And as Dr. Shaw outlined earlier on, really the first branch point is this cancer or not cancer is what you're trying to get at with your focused history. And when you're thinking about breast cancer in particularly, you're focused on the things that predispose women to breast cancer. That tends to be things like duration of estrogen exposure. So you want to know when they first had their first period, whether they have undergone menopause or not, whether they've had exposure to exogenous estrogens, whether they've taken oral contraceptive pills, whether they have breastfed their children, and if so, for how long. All of these influence the duration and extent of estrogen exposure, and all of them have been independently shown to be associated with an increased risk of developing breast cancer in the future. You also want to look at genetic factors. So do they have a genetic predisposition syndrome or a family history of that? So you're asking a lot of questions about the family history in relation to first degree and other relatives who have had either breast cancer or other types of cancer. And then you are asking about previous radiation exposures as well, as that can predispose some women to develop breast cancers, particularly kids who had lymphoma and were treated with a mantle field are at risk for developing breast cancer in the future. So you want to ask about previous exposure to radiation. It also inform their capacity to re-undergo radiation treatment if they are deemed a breast conserving surgery candidate. And so these are the types of things that you're going over the history. And also, if this is a palpable versus a non-palpable mass, did they feel it first? How long have they felt it for? Have they been getting screening mammograms? And if so, when did they first start? Have they ever had abnormalities on any of their mammograms? Have they had a previous breast biopsy? These are all questions that you're really trying to get at to understand whether they are at risk for developing breast cancer.
Great. Thank you very much, Dr. Spears. So for exactly as was mentioned for this patient, she had her menarche at 14, menopause around 55. She's a G3P2 mother with her age at first delivery of 34. She did breastfeed during that and did not use any OCPs or hormone replacement. She's been screening with mammograms since the age of 50, and she has had a removal of a phyllodes tumor and a fibroadenoma several years back. Family history is only remarkable for a breast cancer and a maternal aunt in her 60s. And she did not have any previous radiation or chemotherapy. Physical was remarkable for an exam of both breasts performed in supine and seated positions with no evidence of apparent lumps or masses on inspection and palpation. There also was no appreciated lymphadenopathy locally. So here are some images of her mammography, and in particular of her right breast. So that's what the R is for in both of these. And so this was read particularly for this sort of like spot in this ellipse as a BIRADS 4B in the right breast. And so I would ask the panel, perhaps Dr. Gillespie, what you would sort of think is the significance of such findings in mammograms, as well as like what do you generally look for? How would you read a mammogram?
Sure. Yeah, so with screening mammograms, we typically get the one you see on the right, which is like a craniocaudal view, which means that we're coming at it from up and below. So they'll put the marker on the lateral side. So this is showing you that this is, we know this is the right breast, but this is the lateral side of the breast. So this is like the medial breastbone. And then on the figure, I mean, as you scroll in, you can see that these, are most notable for being, calcifications or little white spots, which, the radiologists read, a million times more per day than we do. The other comment I'll make about, the other view that you get with a screening mammogram is called a medial lateral oblique. And so while you get one this way, the other one is actually at an angle this way, which helps you catch kind of under the arm. And there's a muscle that goes, the pec muscle that goes up to the shoulder. And that's what you can actually see there in the white at an angle is actually the pec muscle. And that's a sign of a good mammogram. It actually, you can sometimes see a couple lymph nodes up there. So this view also, between the two views, because you have two directions, you can actually kind of orient within 4 quadrants, like where the abnormality might be for future biopsy maybe.
Yeah, exactly. Thank you very much. So we'll go ahead and ask a poll at this time, which is what you would recommend next, like almost all of our questions. Do you think we should recommend close observation with a 6-month repeat clinical exam? Do you think we should go for a stereotactic guided biopsy, get a breast MRI, or go for a surgical lumpectomy? Okay, great. So majority of our respondents think at this point it would be best to get a stereotactic guided biopsy. Some think perhaps we have enough evidence to go for a lumpectomy, while others may want to characterize it more with an MRI. And some think that we, can perhaps get away with a 6-month repeat clinical exam. So Kate Horst, what do you think would be sort of like your next step, and how would you walk through this?
Okay, great, thanks. So yeah, I agree with the majority of going with the stereotactic guided biopsy. Years and years ago, they used to just go straight to surgery, and that would be an excisional biopsy. But with the inventions of these needle biopsies, that you can go ahead and get pathology, and that can help better plan your surgery. And so a lot of times, if it's just seen on mammography, we'll do a stereotactic biopsy, which is basically using mammography to guide your biopsy. And often then they deploy a clip so that then going and planning for surgery, they will be able to identify the area. Now, if something is, a lot of times, sometimes here, we'll go ahead and do an ultrasound as well. Now, this was mostly calcification, so it's very likely that nothing would have shown up on ultrasound, but if there is a mass, they'll do an ultrasound, and often then they'll do biopsy under ultrasound guidance, which is a little bit easier for the patient than under stereotactic guidance. And also would deploy a clip to help the surgeon identify the area later.
Yeah, exactly. So she ended up getting the stereotactic biopsy, which we see some images of here on the right. And I sort of configured these to show you that this is like before and this is after. So it's almost the same configuration, except here you can see the sort of core part of the needle go into the calcifications that we're aiming at, and the same with this image. And so maybe I can have the panel just briefly review kind of like what the difference between a stereotactic biopsy versus like a non-stereotactic biopsy is, because it's not obvious even to residents sometimes.
I can
go ahead.
Go for that one too. So the word stereotactic, like what does that mean? I mean, we typically think of that, there's a dog, as being a mammogram. Like, if the findings on a mammogram, a stereotactic is using that mammogram for image guidance, whereas an ultrasound guided biopsy would actually be, as Dr. Horst mentioned, using just an ultrasound. And typically the ultrasound is just easier to do, and it's a little bit easier for the patient. And so if you can see the lesion on an ultrasound, the radiologists are typically going to prefer to do what's an ultrasound guided biopsy than if you imagine a stereotactic one is a little bit like, playing some sort of battleship where they can't necessarily just kind of see it immediately and go right into it.
Yeah, exactly. So we ended up getting the pathology results from this biopsy, and the diagnosis was read as an invasive ductal carcinoma, approximately 0.4 cms, but this, remember, is just from the biopsy, not the whole specimen. They were also able to do molecular characterization, found that it was ER/PR positive and HER2 negative by FISH. It was rated grade 1 out of 3. Again, it was 0.4 cms in the biopsy sample, and no definitive DCIS, which is carcinoma in situ, nor LVSI, which is lymphovascular space invasion, was identified. So I asked Dr. Spears, perhaps you can review what some of these pathologic findings mean. How would they potentially guide management of some of these women? Oh, I think you're muted, sorry.
Apologies. So most of the information that you get back in your pathology report is relevant for some reason. And so going through it kind of line by line, there are decisions that will be made based on the information that is presented. For example, there are different histologies with breast cancer, and the treatments for them can be slightly different. So the fact that this is an invasive ductal carcinoma, there are other histologies that may suggest a more aggressive or less aggressive histology. Invasive lobular or tubular have different likelihoods of spread to the lymph nodes and aggressiveness that may inform both your surgery and your axillary management. A lot of what we do, certainly in the systemic therapy phase, but also prognostic, is the expression of estrogen receptor and amplification of HER2. And so knowing whether you have an ER amplified or expressing tumor or a HER2 enriched or amplified tumor is very important to guide systemic therapy discussions. PR also trends closely with ER, but an ER high and PR low, there's some suggestion those patients have a worse prognosis as well. Certainly grade of the tumor, just like we were talking about with sarcoma, is important, again, in assessing how proliferative the cancer is, and therefore how likely it is to be a little bit more aggressive, with the grading system being from 1 to 3. So in this case, it's a ER positive, low grade invasive ductal carcinoma. Associated DCIS, again, has implications for surgical management, and how extensive that is can clue the surgeon in into how wide their margins might need to be at time of surgery. And then lymphovascular space invasion with most cancers is associated with a higher risk of nodal and distant metastasis. And so we pay attention to whether that's identified at all at time of biopsy. So all of these factors will play into helping us decide what type of surgical management to recommend, as well as what systemic therapy the patient might be receiving in the future.
Yep, exactly. Thank you very much.
The only thing,
yep.
This is I was going to add one thing. The only other thing, I think Dr. Spears nailed it on the head, is when I look at this pathology report, to me, it looks, in a 60-year-old woman like a very low risk breast cancer. You see ER positive invasive ductal grade 1. This would be where I see a patient preoperatively. I think most of us would see the patient in conjunction with the surgeon, and we'd be talking about de-intensifying treatment. So I look at this path report for a biopsy, and I'm talking to this patient, about partial breast irradiation, for example, compared to, for example, whole breast radiation. I'm talking about omitting a boost in a 60-year-old with a luminal A, ER positive. I think part of what we in radiation oncology get to do is we get to be a part of the conversation before and after surgery for breast patients and really help tell a story for them. So looking at this path report, that's the story I would tell them, that you have a low risk breast cancer, you can't make a bad choice, and you have a couple adjuvant options following lumpectomy to think about.
Exactly, which is sort of the perfect way segue to the next question. So hopefully we'll try to get this one correct, which is, what would you recommend next? Would you want to get a CT chest, abdomen, pelvis? Would you want to do whole breast radiation therapy? Would you want to start with tamoxifen therapy, or proceed with a surgical lumpectomy resection? Great. So here are our results, which is pretty good. So most people recognize that, as Dr. Shah said, the whole breast radiation would not be first. It would be in the adjuvant setting. Though some people weren't sure whether you would just go straight to surgery or whether you would need to fully stage this patient. So this might be a good point for the panel to briefly discuss about what would you do with this sort of, like Dr. Shah said, kind of like early stage favorable breast cancer patient.
I think maybe I'll just jump in real quick. So I think the question is, when do you use staging? And as Dr. Shah mentioned, just based on the fact that this is low grade with no suspicious lymph nodes identified, I'm assuming on axillary ultrasound at time of mammography in an older patient, we know from multiple previous studies that the likelihood that this patient has distant metastatic disease at presentation is incredibly low. Therefore, the expense and radiation exposure for full CT chest, abdomen, pelvis to stage the patient completely and look for distant disease is very low yield. And we tend to not do that in patients with these low-grade ER-positive small tumors. Whereas if upfront you had identified a patient with a different histology, if they had presented, for example, with skin changes that were suggestive of inflammatory breast cancer, or if you palpated multiple nodes in the axilla suggesting that the cancer had already spread to those lymph nodes, those are indications then for doing upfront staging, again, to guide upfront management. So these might be patients that you would consider doing chemotherapy before you took them to surgery because they are a much higher risk. In this particular case, because it was low grade, small, ER positive with no palpable or clinical findings, it's perfectly appropriate to proceed to lumpectomy or surgery. But for someone with node positive disease or with a different histology presenting or different diagnosis like inflammatory breast cancer, there you would undergo staging of the patient before you proceed to surgery.
Great, thank you very much. And yeah, the purpose of these questions is really just to like get an idea of when you would do different things, not to, see if you actually know what you would do next in this patient. So she ends up going to surgery and she gets the right breast lumpectomy with sentinel lymph node sampling, and pathology returns invasive ductal carcinoma, which we agreed with the path from biopsy. It's 0.7 cm in size, still remains grade 1. It remains ER/PR positive, HER2 negative, and they find 0 out of 3 positive lymph nodes. It was deemed negative margins with 4 millimeters being the closest. And again, we didn't find any DCIS or LBSI. So Dr. Horst, how would you stage this patient's cancer formally now that we have the pathology results?
Yeah, great. I was just looking at the chat room. Somebody was asking about sentinel lymph node biopsy. So maybe I'll talk about that real quickly. Sure. And then go to that. So yeah, whenever we have an invasive cancer, the standard now is to do a sentinel lymph node, which is basically the surgeon goes in, injects a radioactive tracer or a blue dye, and then follows that to the first echelon of potential spread. And they'll take it out and intraoperatively often, or it used to be that the pathologist would look at it in the operating room to give a diagnosis of whether there's metastases or not. Historically, it used to be that if the sentinel node was positive, then the patient would go on for a completion node dissection. That's kind of changed over the last few years, such that even if there's a small area of focus in the lymph node, then we don't go on to completion node dissection, but rather use radiotherapy. But nonetheless, sometimes in older women, the surgeons will not do a sentinel lymph node biopsy. In fact, the ongoing study in Europe looking at randomly assigning women who are clinically node negative to a sentinel node biopsy or not. And because I think what we're realizing is we're doing more sentinel lymph node biopsies in these low risk patients. And while it doesn't have a lot of toxicity, they still have a lot of they have numbness, arm pain, and of course it's a low risk, but still a small risk of lymphedema. So in this patient, as we had hypothesized, who was a low risk, very small tumor with no lymph node involvement, so she's stage 1. So it's a T1B, and that's based on the size of 7 millimeters, which is between 5 millimeters and 1 centimeter. Node negative because the nodes were uninvolved. And so getting back to the other comments, with a stage 1 breast cancer, we don't typically do additional imaging because the probability of finding metastatic disease is very low.
Thank you very much. Great. So I think we have another poll for everyone. So what would you recommend next? Would we sort of observe at this point? Should we do adjuvant radiation? Should we start tamoxifen now, or should we offer chemotherapy? Okay, great. So most participants think that since this is a radiation oncology talk, we should probably offer some form of radiation therapy. But there is a mixture as to what people think may be the correct answer, and for good reason, because she is ER positive, and chemo may have a role in breast cancer, and so may observation if she's early enough. So I would perhaps ask one of the panelists, Dr. Shaw, what do you think we should do next for this early stage patient?
So I actually think all of these answers are correct under the right context. So if you think about we in the past tried to do this, and for the students, almost every research question has been studied once before, but is often looked at under a new lens. So we tried this work in the past, and we thought, oh, all patients need radiation. Well, it turns out that's absolutely not the case. So a trial that was done in Canada, when analyzed, found low-risk biologies like this patient's, even at 60 years of age, didn't get much benefit from radiation. So you could, in theory, observe with consideration for endocrine therapy, though in a 60-year-old, it's more likely to be an aromatase inhibitor as she's postmenopausal rather than tamoxifen. Whole breast radiation has been the standard following lumpectomy for decades. We went from 5 weeks, which is standard, to 3 weeks, and that's very standard to this date. And then chemotherapy, a lot of medical oncologists may not even order an oncotype in this patient, but some would consider ordering an oncotype and might, and if it was a high-risk oncotype, would consider chemo. The last option would be some form of partial breast irradiation. She's 60 with a stage 1 breast cancer that's ER positive with negative margins. So you could consider partial breast with a lot of different options available at that time.
Exactly. So we ended up offering her adjuvant radiation with whole breast radiation, and part of that was because of a discussion with the patient when multiple options for the different forms of radiation were offered. And so given that this was what she opted for, perhaps Dr. Jalipsy, you may give us your thoughts on how you would set her up for treatment, and then what would be your target volume and what dose you would prescribe.
Yeah, so when we treat with whole breast radiation, the patients are usually lying on their back, which is called supine, and on like what's called a breastboard, which is sort of angled up like 10 degrees or so. And then let's see, our target volume, right? So the fields are essentially generally called tangents, which means actually two fields that look like this get angled, so they're not directly opposing fields, but they're actually tangent fields. And in that field, we're trying to treat the whole breast, which is, on the, we used to use bony landmarks like the midline and, the clavicle and the lateral, but you can also look at the CT scan to actually see breast tissue to some extent. And then we generally do outline the tumor bed or where the tumor was, which, sometimes if the surgeons leave clips, that can be helpful. Sometimes you see a seroma. And, if you can't really see it at all, you should always, go back to your mammograms and any diagnostic imaging and just make sure that you're you understand where it was. Also, sorry, I should mention at the simulation, they'll put a wire where the incision was, and that can also help guide you, although there's now, that you can't always rely on that. Although we used to boost patients just based on where that incision was. So, and, at the end of the day, I agree, Dr. Shaw mentioned all this tumor bed, trying to find the tumor bed. We may not actually boost this patient. We probably don't need to. So I don't need to specifically treat that one little spot. But certainly making sure that it's within the tangent. So right now what we're looking at are those tangents I was talking about. I think you can see kind of that, if you've outlined the tumor bed, then you can see on what your DRR, basically, that the tumor bed is within the fields that you've set. And then you can also look at it on the 3D, the CT slices as well. And then here we're looking at the actual dose distribution. So once you set the tangents, your dosimetrist or physicist will actually calculate the dose distribution. Does anybody else want to take a stab at talking about the plan? I'll stop talking.
Go ahead.
Go ahead, Dr. Shaw.
I was going to say, in terms of looking at the plan, this is the beauty of breast radiation oncology in general, is there's so many ways to do this. So some folks will actually draw out all of the breast tissue, which is an absolutely appropriate way to do it. What I typically do is just put wires at the edges of the breast tissue, and then I make sure that I'm getting the dose that I want where I want. So typically when you look at a plan for dose, I'm looking at basically a couple things. Number one, am I covering what I need to cover? Number two, am I avoiding what I don't want to treat? And number three, am I really maximizing the therapeutic ratio, meaning giving the best opportunity for help and the least opportunity for harm? And so this is basically a color wash, which for the students is you can see the different gradients of the color and they're labeled based on that. You can also look at them as lines rather than as this kind of spray painted kind of over looking at the radiation doses. And I typically look at the coverage, which would be 40 gray. I look at 95 or so percent, around 38 gray, and I'll look at a hotspot, which is around 105% or 42 gray, and trying to minimize that. And then I'll separately look at what the low dose lines are, looking at the organs, the lungs and the heart. And I don't know if we have a DVH, but what we do is we pictographically see this, and then we turn that into numbers, meaning what dose is received by each structure and what percentage of that. And that helps us meet standardized constraints and guidelines.
Yeah, thank you very much.
I'll just make a comment. Somebody asked about prone positioning. So yes, there are prone tables that you can set the patient up and treat in the prone position, which is a nice way of treating the breast because it gets pulled away from the chest wall. So you can sometimes minimize dose to lung in that situation. Sometimes it's actually a little bit misleading because on the left, sometimes the heart actually falls a little bit more anteriorly. So sometimes it seems like it would be a good use on the left, but sometimes not. It varies depending on people's anatomy.
Yeah, thank you very much. So she completed this course and then afterwards got her adjuvant treatment with anastrozole, which is an aromatase inhibitor, like Dr. Shaw was mentioning, is more appropriate for her age group than tamoxifen. And so we want to sort of move on to the next case, but we had some variations here which talked about, would you consider APBI? What about other forms of hyperfractionation such as IORT, and in which patients would you consider omission of radiation? And I also think one of the chat attendees, Ilio, asked a great question, which is, would you offer APBI if she had associated DCIS, which is a good point because a lot of people think of DCIS as sort of multifocal and it may be outside of where you would partially treat the breast. So I don't know if Dr. Horst, you want to sort of talk about that, or anyone, Dr. Spears.
The DCS, I'll just comment real quickly about that. So historically, and this is kind of, again, going back years and years ago when they first started doing breast conservation, anyone who is identified as having what's called an extensive intraductal component, or EIC, was not offered lumpectomy because the thought was that they would have higher chance of recurrence within the breast. Obviously, over the years, we've better defined that, and if you can get good margins around the DCS, then the risk of recurrence is not unacceptably high, so these patients can get breast conservation therapy. But interestingly, moving into this era of PBI, that's when there is a little caution about that component as well. I think with an associated DCS, I agree with Dr. Shaw, I would feel comfortable doing PBI unless there was an extensive area. And I think that still is an area that we want to make sure you get wide margins around it and probably want to be more comprehensive with whole breast radiation. Currently, this is also a conversation that could take a long time because it's very interesting, but there have been lots of different debates back and forth about which patients are most appropriate for APBI. And the current consensus guidelines suggest that anyone over the age of 50 with small ER-positive tumors that are node negative. That being said, the randomized trials did include a broader group of patients. So I think there's still some conversation about whether to include node-positive patients, for example. We do IORT here at Stanford, limited to women with small tumors that are node negative. And other panelists want to comment as well.
Sure. So we do IORT. Also, there's IORT guidelines out there. So, you know, for the students, this is an area of extreme controversy in our specialty in terms of the role of IORT. You know, my take is I only offer IORT to patients I consider omitting radiation in, frankly speaking. So someone who's 65 or older with a T1N0 ER positive, because the other PBI techniques have not been shown to have a difference in recurrence of more than 1%, but Target and Elliott both did, albeit with slightly different patient populations. So I offer it to a few patients, but I've kind of gotten patients to believe that, you know, if you have 5-fraction partial breast, why do a single fraction with inferior outcomes? So I think a lot of that has to do with patient selection, but definitely a work in progress.
Great. Thank you, everyone. So I pass it over to Chris, who will be taking over for case 3.
Thanks, JP. A lot of great discussion. So for this case, let's see if I can get it working. This is a 56-year-old female who underwent routine screening mammography, revealed diffuse calcifications and a mass in the upper outer quadrant of the left breast, who comes to your clinic. The first question is fairly basic, that the students in the audience would probably like to hear your thoughts. Dr. Gillespie, would you comment on your comprehensive breast exam?
So yeah, I think a comprehensive, you know, or I guess we would kind of, you could call it a comprehensive history and physical with a focus on a breast exam, if you were like doing an oral boards, where the breast exam is really, you know, you're palpating for any abnormalities, abnormal lesions. You're looking, you know, things like expressing the nipple, things like that. I don't think we routinely do anymore. You know, you certainly palpate for lymph nodes. I think that's the most useful part of my exam, particularly in the post-operative or if we see the patient's preoperative setting. And those nodes can certainly be under the arm or under the clavicle.
Great, thank you. Yeah, I should have mentioned there were no other significant findings on her history. What other tests or studies would you like to obtain in this patient? After you did a physical exam, you palpated this firm regular mass in the left upper outer quadrant. And maybe Dr. Horst.
Okay, so she had thus far just a screening mammogram, and so it showed an abnormality as well as on exam. So we would typically get a diagnostic mammogram and an ultrasound of the breast, and often now we're getting ultrasound of the axilla as well. I don't know if you there's any comment about whether there was a palpable node or not, but that would be another test that we would get.
All right, thank you. And we actually already had a fairly comprehensive discussion about mammography, so I'll skip this slide. And Dr. Shaw, could you comment on the findings of the ultrasound of this of her left breast?
Sure. So, you know, in terms of ultrasound, I think for the students, it's important to know that we do ultrasound for a couple reasons, first and foremost. So first, it's to better characterize a mass. Number two, it's really important to understand kind of the axilla. And though we get some of the axilla and mammograms, as Dr. Gillespie noted, ultrasound of the axilla is a great way to really define a patient as clinically node negative. One of the things that ultrasound gives us that mammogram doesn't give us is it can kind of characterize a mass. So whether it's cystic, whether it's complex, whether it's got solid, whether it's taller than it is wide, which is a kind of old thing, but I think still sometimes used by some folks to say, well, this is a higher risk of malignancy. Also, if something is not very clearly seen on mammogram, it can be subsequently imaged on ultrasound and potentially biopsied. So when I'm looking at this on ultrasound, I'm obviously looking at the left breast at the 6 o'clock position. And for the medical students, if you look at this, this means 2 centimeters from the nipple. T2CMFN means 2 centimeters from the nipple. It also gives you the relative depth to the surface for that, which can help you in terms of surgical planning, as well as in terms of you're looking at this and you didn't know where the boost cavity was. This would be helpful. And what I see here is basically, it looks like at least a single lesion. Obviously, you know, we'd look at multiple parts to see if there's any other masses within the breast or any other axillary adenopathy.
Awesome, thank you. And as you mentioned, there were 3 separate masses in the left upper outer quadrant of the breast, and multiple axillary lymph nodes, which I did not show. And we had a discussion about completion staging, which she had performed, and shows some left axillary lymphadenopathy. An MRI of the breast was performed and demonstrated these 3 masses, with one mass actually extending down to the pectoralis fascia. So our first poll of this case is, what would be the next step in your management? It's not popping up for me. There we go. All right. So it looks like almost everyone wanted to get an ultrasound guided biopsy of one of the masses. Dr. Spears, would you be able to comment on this?
Yeah, I mean, I think you want to establish a diagnosis, right? So we have a lot of clinical suspicion that she has a malignancy. We have radiographic evidence that suggests that there's a malignancy there that has likely spread to the lymph nodes, but we don't have confirmation of that. And so putting a needle into both the tumors in the breast, and at our institution, we would sample each of them probably with a clip being placed. And we would also, in the very least, do an FNA, if not a core needle of the axilla, at least one of the suspicious lymph nodes to confirm metastatic disease to the lymph nodes, as this will guide our approach to these patients, which I think we'll talk about in just a sec.
Great, thank you. So on the pathology report, we actually discussed this question earlier, I believe by Dr. Spears. And so in this case, she had moderately differentiated invasive mammary carcinoma, hormone receptor and HER2/neu positive of low-grade DCIS. And a left axillary lymph node was positive for carcinoma, as you mentioned. What would be the next step in your multidisciplinary approach? Perhaps back to Dr. Gillespie.
All right, so we have a couple tumors in the breast and a positive lymph node on biopsy, which would make it a clinical node positive, or typically N1 if it's mobile mass. But most people, most patients that are node positive now are going on to neoadjuvant chemo or chemo before surgery. So I would certainly have them see a medical oncologist and talk about that.
Great, and we will get to that in just a second. Dr. Horst, when would you or your team consider a genetic consultation?
Yeah, great, thanks, because I was thinking about that. So certainly women under 50 should be referred for genetics. The NCCN guidelines actually include also women with triple negative breast cancers, which this is not, anyone up to age 60. And then anyone with a strong family history would definitely want to be sent to the genetics counselors as well. I find that we're actually sending quite a few people now to genetics, even though they may be borderline in terms of what the NCCN guidelines suggest, because what we're realizing now is, in addition to BRCA1 and 2, these wider panels are identifying not only additional mutations, but variants of uncertain significance, which don't necessarily change what we do, but certainly as we move forward, we're going to learn more and more about these. So this patient I would definitely send to genetics.
Great.
Which is an interesting, I'll just add, this, this comment about variants of unknown significance, if it comes up, the vast majorities of the variants end up being benign. It's just that, it's flagged as something that's abnormal, or like we don't have enough information. But we do know that as more and more patients get these genetic tests and they get these questionable findings, it does lead them to do more aggressive surgeries like mastectomies. So, I'm glad Dr. Horst brought that up, but it's just something to be aware of, that it's kind of like in that line of, sometimes too much testing can lead you down paths when we don't necessarily know what's best for the patient.
And this woman, being 47, was seen by genetics, and her workup was completely negative. And she did, as Dr. Gillespie mentioned, undergo neoadjuvant therapy, which was 4 different types of chemotherapy, with a partial response by imaging. And so, Dr. Shaw, I believe we're at. What type of surgery would your surgeons consider at this point?
So looking at those 3 areas, I don't think they're all in the same quadrant. So for the students, we typically break up the breast into 4 quadrants. And so if there's multiple areas and they're not in the same quadrant, we by and large will consider a mastectomy. And I think she had 3 areas on ultrasound that were concerning, but it looked like only 1 was biopsy. But we would typically, in that case, do a mastectomy. It is evolving, and there are some people who will do multiple lumpectomies. It's being studied. But outside of a trial or an abnormal situation with 3 areas that were concerning, we would typically do a mastectomy. And we would typically start with a sentinel lymph node. And if there was nodes positive at sentinel lymph node, we would then most likely, outside of a trial, proceed to axillary lymph node dissection following neoadjuvant chemotherapy.
Perfect. So she did undergo a bilateral nipple-sparing mastectomy with sentinel lymph node biopsy, with a YP T1C tumor with 2 out of 4 positive nodes post-chemotherapy, both in level 2 at the time of surgery, with LVSI and overall negative margins. She did well post-op, and she's then seen probably again in your clinic. And if Dr. Spears could comment on just the types of reconstruction that is sometimes discussed and how this affects your treatment planning.
Yeah, sure. Happy to talk about that. I want to go back real quick. So some of you may be asking, and I see some of these questions about the role of neoadjuvant chemotherapy and why one might give chemo before surgery, and why not just go straight to surgery, take it out, and then do the chemotherapy. What we have learned from a number of trials that have looked at this approach of using chemotherapy beforehand is that assessing the response of the tumor both in the breast tissue itself as well as in the axillary area is really important prognostically, and can guide subsequent decision-making about what to do in terms of treatment. And it can guide our ability to offer our breast-conserving surgery. It can dictate what fields we would treat with after surgery in terms of radiation fields. So there's really an increasing role for patients to have chemotherapy up front, especially in a patient, for example, with HER2 positive disease like this patient was. We know that their path CR rates are much higher with the TCHP dual agent regimen. And the fact that this woman in particular had residual nodal disease after chemotherapy up front suggests that she's at much higher risk of both local regional failure and distant metastasis, which will influence the types of adjuvant therapies that are recommended. You asked specifically about reconstruction and post-mastectomy radiation. For a woman who had no positive disease that after neoadjuvant chemotherapy still has nodes that are positive, I think most of us would recommend post-mastectomy radiation in this case. And this is where I'm very interested to hear the rest of the panel, because I know Dr. Gillespie and Memorial Sloan Kettering, for example, view this a little bit differently than our institution does. But our policy has tended to be, based on some data, that we try and defer post-mastectomy reconstruction until after the completion of radiation. And so we favor a delayed reconstruction approach. There's a number of ways in which one can do a reconstruction. It can be immediate or delayed. It can be with the patient's own tissue, so an autologous skin graft or a flap, versus expander and implant based. So there's a lot of consideration surgically about how one might do the reconstruction, but also considerations about the timing of that reconstruction. And our institutional bias has been towards a delayed autologous reconstruction in patients for whom adjuvant radiation is indicated, like this woman would be. And again, others around the country can comment because their institutional practices are perhaps quite different than that.
Yeah, I think Dr. Shaw and I were tweeting about this just yesterday. Like, you know, I agree that the patients that actually get an autologous or like a flap reconstruction tend to be happier at long term, and there are less side effects. You know, if you look at people that got an autologous reconstruction who got radiation or didn't, radiation tends to impact the outcomes less when it's a flap than with an expander, which the expander, and then after you expand the tissue, they switch it out for a permanent implant. But, you know, for whatever reason, we at my institution, like most patients, whether it's patient preference or surgeon preference, but a lot of them do the expanders and the implant route. I think it's less invasive surgery. And then this question of like, you know, I think even as a resident, it took me a while to really like grasp all the different options there were with this. Like, because then whether you do a flap or a expander, and then you have to decide, are you going to do it before radiation or like 6 months after radiation? So the immediate refers to just like kind of before radiation versus like delayed being, you know, waiting to heal and see where things are at after radiation. But you know, I'm assuming you guys aren't doing like expanders 6 months after radiation. It's only the flap, right?
So at Michigan, they'll do expanders, delayed expanders as well, but it tends to be, we tend to favor the autologous flap, but obviously that's dependent on body habitus and the ability to get a flap. If you have someone that's very thin and with not a lot of tissue, that's a much harder reconstruction to do and not an option.
Yeah.
I'll comment quickly. At Stanford, we've been mostly doing tissue expanders and then exchange them out for implant, but our plastic surgeons now have been doing pre-pectoral. So it used to be they would put it under the pectoral muscle, but now they're putting it on top of the pectoral muscle. So I think that we're going to be seeing a little bit less complications with that approach, but they've only recently done that.
Yeah, I mean, so it's been a big change in the last few years, and we tend to do mostly a delayed approach like Dr. Spears, and I think the data that he's actually published as well as others show autologous tends to have less, and our institution has shown the same. We do mostly expander implant here, but I will say the pre-pectoral has changed the game for me in that I think it's much more difficult to treat patients, particularly when I treat their internal mammary nodes, with a pre-pectoral implant, because you can't use a partially wide tangent, which for the students and residents, where you basically take that standard tangent Dr. Gillespie talked about and you open it up to cover the lymph nodes between the first few ribs. And you can't use a technique of matching fields. So you end up using IMRT or intensity modulation, where you are basically using a much more expensive technique. So one of the things that I've really talked to our team here about and others is, pre-pectoral implants can also increase the cost of care by requiring more IMRT, which I would argue is not a value proposition in terms of IMRT versus 3D. So, for the students and the residents, some of these choices have downstream effects on, radiation techniques and treatment.
Great, thank you. And so this being a left-sided disease, I think we're back to Dr. Spears. How would you simulate this patient, and why is being left-sided interesting or different in this case?
Yeah, so we had a good discussion about all of the considerations one needs to take when you're thinking about how to do your reconstruction and when to do your reconstruction, because it really impacts the way in which we can treat women in the post-mastectomy setting. As Dr. Shaw mentioned, if you're going to treat the internal mammary nodes, a prepectoral implant is very, very challenging to do that dosimetrically. And so in this particular situation, when you're talking about a patient with left-sided disease, you're obviously worried about the organs at risk as well. So you want to make sure that you can cover the chest wall and the draining lymphatics, because this woman still had residual disease both in the breast and in the axilla, even after chemotherapy, which suggests that the rates of local regional recurrence are going to be much higher from the previous trials looking at neoadjuvant chemotherapy. So you're going to need to treat those areas. And the question is, how are you going to do that safely? So for a patient that's left-sided and in a mastectomy setting, really prone isn't an option or isn't a good option there, because you can't treat the draining lymphatics as easily. So you're talking about treating someone supine, and for the left side, we have favored an approach in which we can minimize the lung and heart dose by using an SDX device, which allows us to modulate the breathing of a patient such that they take a deep breath, they hold that breath in, the radiation beam turns on, and as they expand their lungs, there's less fractional volume of the lung tissue that's irradiated, and the heart, as the lungs expand, falls away from the chest wall such that you have to give less dose to the heart as well. So we tend to simulate these patients supine using an SDX device, their arms above their head. We will put bolus on their skin, because this is post-mastectomy, to bring the surface dose up to the skin. The question about dose and fractionation is kind of a loaded one in the COVID era. In the past, the standard answer has been 50 gray in 25 fractions with an optional 10 gray boost. And there's some data first piloted, frankly, by the UK group and John Yarnold, and then also Bruce Hafty and Atif Khan have published some nice data on using hypofractionated regimens in women, both post-mastectomy with and without implant expanders. And there's a trial ongoing right now called RT Charm that is allowing us to explore whether hypofractionation in this setting might be useful. So our approach off trial has continued to be standard fractionation, 50 and 25 fractions with an optional boost, though it wouldn't be crazy to consider doing a moderately hypofractionated treatment, even in a node positive patient, though that's being explored on a number of trials right now.
Great. I think you answered a few questions as well in the future, but Dr. Gillespie, would you be able to comment on this beam arrangement and setup, and perhaps discuss what this is on the 3D rendering?
Yeah, I think we're coming to the end of our time together, so I'll be brief. I think the upper left that we're looking at is what people call a partially wide tangent, which I think Dr. Shaw was referring to earlier, is actually pulling that medial border like posteriorly, so that you actually at a higher level would be adequately covering those internal mammaries, which sit between the sternum and the rib, essentially. And then in the lower left is the supraclav field, which is more en face, but angled a little bit off, like the esophagus and spinal cord. And then we're looking at the isodose lines, where probably the red or orange is the 95%. I can't really read that, but
I think this is 100.
And then in the lower, yeah, so you're looking for the absolute dose of, whether if you 50 gray, if that's what you picked for your fractionation, and then and the 95%, as mentioned earlier. And then on the right is, this is the skin rendering. So you're just able to see where does the radiation dose actually hit the skin. So you can, easily see on this view, are you actually going onto the other breast, which can be helpful. But otherwise, you're seeing in yellow that supraclavicular on FOSS field, and then in green are the tangents.
Great. And could you comment what this breathing device is and when you might use it in our last minute? Maybe Dr. Horst?
Well, when I first saw this, I wasn't sure because we don't use that. I think Dr. Spears uses it. So you want to comment on that?
Yeah, sure, Dr. Spears.
I guess ask the person that uses this. So this is an example of the SDX device. So it's basically, if you've ever scuba dived or snorkeled, it's the essentially a device that connects into the mouth. You put your mouth around, it connects to an outside breathing apparatus. The patient wears goggles. There's a nose clip over their nose. And they modulate their own breathing. So the goggles will give them a visual cue to take a deep breath in. The lungs will expand to a certain area that the computer can then sense. And then they will hold their breath in that position from anywhere from 12 to 25 seconds for treatment. During that time, the lungs are expanded, the heart falls away, and that allows us to minimize heart and lung dose just based on kind of the physics of lung expansion and the heart falling away from the chest wall.
Great. So I think that will wrap up this case. I believe we actually answered all of these at some point. The patient did really well with treatment and has remained disease-free. I'll let Dr. Khan finish up for us.
So thank you to everyone who has come, and to all of our panelists, as well as our moderators. Please make sure to fill out the post survey to be entered into the Amazon gift card raffle. Next slide. You can always contact myself or Dr. Pollum, and be sure to look out on radoncvirtual.com. Our next session is on August 20th, and it will be lung cancer. And we have 4 physicians from different institutions, so please sign up for that. Last Rover session of the summer. We'll have one final Rover session in the fall that is targeted towards M3s and M4s that will be breakout sessions discussing applying in radiation oncology and networking. So that's on September 10th. So please sign up for that. On the website on radoncvirtual.com, there are the different institutions that are offering virtual clerkships, as well as times for meet and greets from different institutions. So be sure to check those out as well. Thank you to everyone, and please reach out. We'll send emails and information on this session coming to you shortly. Everyone, bye. Thank you, bye.
Thanks, everybody.
Anna,
Bye.
thanks, Darcy.
Thanks, everyone.